We can see in this slide, this is the through my slides from the lesion by which Dr. Ujjawal will take. This is a skin biopsy covered by epidermis, which looks atrophy with flattening of the reticulum. 75-year-old woman underlying dermis shows diffuse with multiple lesions over face and composed of serostatus of the patient's and macrophages. She was a known case of diabetes. Here we can notice some the punch biopsy from granulomas over trunk. So these are the granulomas. These are ill-formed granulomas. Slide. This is the punch biopsy we can, from the lesion we could actually. This is a skin biopsy covered by epidermis. Some vacuolated type of homing cytoplasm of flattening of the reticulum, which pointed us to underlying dermis, what shows diffuse, dense infiltrate, composed of histiocytes, lymphocytes, and macrophages. Here we can notice some ill-formed granulomas. So here in this case, we can see that there are n number of yeast-like organisms which have these are ill-formed granulomas with past stain, and we could actually cluster. So these are like in clusters. And because vacuolated type of embedded cytoplasm macrophages as well as they are pointed us to extracellular. So these special stains, these forms, these have this clear zone that is actually composed of the cell wall, a clear zone around them. I will try focusing them in oil so that we get a better view. So here in this case, we can see that there are n number of yeast-like organisms which have stained with past stain, and they are appearing clustered. So these are like in clusters, and because they can see that these embedded inside the macrophages as well as they are nicely surrounded extracellular. Here, so these stains these forms these have this clear cell wall zone that is actually composed of the cell wall, a clear zone around them. So based on this, a diagnosis of them in histoplasma was given. I have some special stain slides which I could not put as slide but in the photographs itself. So GMS was performed which showed these aggregated and narrow based budding yeast forms. This is the same that we have seen on these. So here we can see that these are the yeast forms. Stain was put nicely to differentiate it from Cryptococcus, and stains can have a similar that is made up of yeast forms. But Cryptococcus will be positive for Alcian blue, which was negative in this case. So finally, a diagnosis of based on this, a diagnosis of histoplasma was given. I have some special stain slides which I could not the next slide but in the photographs a 26-year-old female presented GMS was performed in shortness of breath, these aggregated 20 to 25 narrow based budding yeast patient is this is the same that we have seen on these sections of HIV, and the imaging was revealed bilateral ground differentiated from an interlobular septal thickening with consolidations, but Cryptococcus will be positive for Alcian blue, which was negative in this case. So finally, a diagnosis of pneumonia and encapsulated was given for this case. The next case is a 26-year-old female presented with cough and shortness of breath for 20 to 25 days. The patient is seropositive. The patient was known case of HIV, and the imaging revealed bilateral ground glass opacities and interlobular septal thickening with consolidated cells composed of clinical differential diagnosis for this lymphocytes, viral alveolar macrophages, which was very pneumonia, and patchy in these smears was pneumonia. Presence of these foamy type of eosinophilic exudates which were present in the smears. So this is a pap-stained bronchoalveolar lavage fluid for this case. This pap-stained smear is showing this eosinophilic and the type of exudates which are also known as alveolar casts. So in the background we can see inflammatory cells, neutrophils, macrophages, along with alveolar macrophages. What was very catchy in these smears was presence of these foamy type of eosinophilic exudates which were present in the smears. And smears, they revealed. So this is the GMS again revealed and highlighted. This pap-stained smear is showing dates and eosinophilic and numerous foamy type of exudates which are also known as alveolar casts. So, and in the background we can see inflammatory cells, macrophages, and there were some respiratory cystic structures with intracystic dots. They are also known as capsular dots, and they are very strikingly present in these alveolar casts or foamy exudates. And some of them are intact. Smears, and some of them can be seen. The GMS again revealed and highlighted or these eosinophilic exudates. So this is very striking. Presence of the diagnosis of pneumocystis pneumonia, which and the diagnosis of pneumocystis pneumonia was rendered in this case. This case was also positive for ZN. We can see ZN positive for acid fast bacilli, cystic structures, which with central intracystic infection, opportunistic infection, or they are also known as capsular dots, and they are very strikingly present in these alveolar casts or foamy exudates. Some of them are intact, and some of them moving on to the third case. So these are the images from the same case. Here we can see or eosinophilic exudates, which also show some honeycombing or negative shadows, which give a pneumocystis to the diagnosis of pneumocystis and was rendered in this case. GMS case was also positive for ZN positive for acid fast bacilli, which was indicative of. So the case 3 is a 29-year Indian male presented with ENT with progressively increasing nasal obstruction. ENT workup showed red granular polypoidal mass in nasal cavity. Moving on to the third case. So these are the images from that same case. Here we can see these eosinophilic exudates, which also show some honeycombing or negative shadows, which give a clue to the diagnosis of pneumocystis pneumonia. And we can nicely see GMS stained microorganisms. So this is a very classic with nice picture, intracystic, in which we can see polypoidal lesion. The case 3 is a 29-year Indian male presented to ENT nasal cavity progressively increasing nasal obstruction. Metaplastic famous lining granular polypoidal with presence of numerous in nasal cavity, sporangia of varying size or variable size, which are filled with numerous endospores. So these sporangia are basically present in various size, and they represent the various stages of development of the organism. That is a very classic picture. So, in which we can see here polypoidal lesion, which is partially lined by the respiratory epithelium within these sporangia, nasal cavity as well. Partially, some of them metaplastic can also be seen famous lining as empty cysts with presence of numerous. These are lined by sporangia of varying size, or variable size. You can see here, which are filled with numerous endospores. And so in the surrounding tissue, are basically usually there is chronic inflammation, which they represent the lymphocytes, various stages of development of the eosinophils as well as granulomatous response can happen. So, as we can see here, in this case, a diagnosis of rhinosporoidiosis endospores within these sporangia. And some of them can also be seen as empty cysts. So these 34-year-old male with painless swelling and bilateral foot with discharging sinuses. You can see there was a history of extrusion of blackish brown grains, and in the surrounding patient has a classical triad. Usually there is chronic inflammation, which comprises of swelling, of discharging sinus cells, giant cells, and eosinophils as well as granulomatous, which can be variable in appearance as well as size. In this case, a diagnosis of Rhinosporoidiosis was given. This is the same case. So case 4, 34-year male with painless swelling and bilateral foot with discharging overlying epidermis. There was a history of extrusion of blackish, but there might be. So this patient has a classical response of mycetoma, which comprises of swelling, underlying discharging sinus, and inflammatory infiltrate, and we can make out and the extrusion of pigmented, which can pigmented colonies, which are nothing but as well as the same as grains that are the entangled masses of pigmented hyphae. So this is the biopsy that we received from this case. They are surrounded by this very characteristic overlying eosinophilic splendour. Here it looks quite flattened, but there might appreciate over here. Surrounding tissue shows dense inflammation. Underlying there is dense giant cells, inflammatory infiltrate, and we can make out these pigmented colonies, which are nothing but they are the same as grains that are the entangled masses of, and we can figure out pigmented some negative shadows of these fungal hyphae. Surrounding is they are surrounded chronic inflammation, very characteristic eosinophilic splendour phenomena, as we can appreciate over here. The surrounding tissue shows dense inflammation and presence of giant cells, numerous giant cells. This is a pastine, and we can see again here, this is pastine, and we can figure out some negative shadows of these. And pastine is highlighting that these grains or these colonies, they are made up of entangled masses of septate, you can see, chronic inflammation, which are more arranged at the periphery in a as well as numerous giant cells. In this, we can see here, these are the hyphae. This is a pastine, and we can see. So again, for this case, a diagnosis of mycetoma was given based on the clinical as well as the microscopic features. And pastine is highlighting that these grains or these colonies, a differential diagnosis of entangled masses of septate like hyphae comparison, where which are more, these are arranged at the periphery in a radial manner. These colonies are also surrounded by this eosinophilic splendour phenomena, but these are not made up of fungi, but they are formed of higher bacteria, that are the actinomyces, which is seen as branching filamentous bacteria. A diagnosis of surrounded by dense given neutrophilic infiltrate. Usually the inflammation over here is neutrophilic. The colonies are usually they are smaller. A differential diagnosis of actinomycetoma, and the color of the grains can also give us a clue. We can see these are because the grains of actinomyces are never black in color. Colonies, whereas the grains of mycetoma can vary in color. From black are not white of fungi, but they are formed of higher bacteria, that is actinomyces, which is seen as branching filamentous bacteria that we encounter dense neutrophilic routine trait, usually 32-year inflammation over hearing in perineum, and 30 discharge. Colonies are per vagina. They are cervicovaginal. Then that of the eumycetoma. And the color of the grains can also give us a clue, because the grains of actinomyces are never black in color, whereas the grains of eumycetoma can vary in color from black to we can white. See there is dense inflammation, as we can see that there is almost obscuring of the cellularity by intense neutrophilic infiltrate. Encounter in routine 32-year female itching in perineum and curdy discharge per vaginum. Cervicovaginal pap smear was obtained. And could not make out, even though it is not stained with special stains, we can see there's the pseudohyphae, dense inflammation, entangled pseudohyphae. See that Candida, almost obscuring of the cellularity by intense neutrophilic infiltrate with budding mesoforms. And we can also notice alteration in the background flora, which can give a clue. So this was a case of cervicovaginal candidiasis, and could not make out, even though it is not stained with special stains, we can make out the pseudohyphae of entangled pseudohyphae of Candida. With budding mesoforms. And we can also notice alteration in the background flora, which can give a clue. Now I will hand over to Dr. Ujjawal Khurana to present some cervicovaginal candidiasis. I think that's it from my side. Now I will hand over to Dr. Ujjawal Khurana to present some cases. Thank you very much.
Dr. Tanya has been very swift and hassle-free in juggling between the two things, between the microscope and the computer screen. I hope I can also do some justice to all this. So I will be taking you through these cases. So here we have a girl, 1.5-year-old child with these what Dr. Sadi had shown, the annular plaques, and these are the KOH mounts and mycelium and inflammation. And then this young girl, prepubescent, Dr. Tanya had been very hyperpigmented and hassle-free in juggling between the two things, between the microscope and the appearance and this scrape cytology. I hope I can also do some justice to all this. Spaghetti and meatball. So I will be taking you through these cases. So here we have a girl, 1.5-year-old child with these, what Dr. Sadi had shown, the annular plaques, and these are the KOH mounts and mycelium and inflammation. And then this young girl, prepubescent girl with hyperpigmented, this and the KOH preparation shows these spaghetti and meatballs appearance, and this scrape cytology shows the spaghetti and hyphae and the meatballs. So this is what Malacia furfur or in the patient. So these, if you do past staining, you can keep the slides forever because these are fixed, and this is just to show that. So this is the similar what I had shown you with the picture. This is the straight cytology smear. This is a case of a 21-year-old female. We had received 2 punch biopsies from the vesicular lesion, hyphae, and this is the HNE stain, and we can see a vesicle formation and not much on HNE stain. So these, if you do past staining, you can keep the slides forever. There is this pink lace-like thing appearing, and which on closer looks, we are having these hyphal structures throughout the at the interface between stratum corneum and granulosum. They are very beautifully seen, and they are inside the case of inside the vesicle also. So this is received 2 punch biopsies from the vesicular lesion, dermatophytosis with Spongiotic Dermatitis, and we can see a vesicle formation slide now, and not much on HNE stain, and some on pass near the stratum corneum, there is this pink lace-like thing appearing, and which on closer looks, we are having these hyphal structures throughout this vesicle, what I had shown you in the photograph, corneum and not much to be seen, but yes, inflammation is inside in the dermis also, inside the vesicle also. So this is a case of dermatophytosis with spongiotic dermatitis. So I will show you the slide now. So there is some busyness out here, but not much we can make on HNE stain. So this vesicle, what I had shown you in the photograph, not much to be seen, but yes, inflammation is down in the dermis also and slightly subjacent also. So pus has made our task so easy that there is this dermatophytes. Okay, and this is spongiotic dermatitis with dermatophytosis. So there is some busyness out here, but not much we can make on HNE stain. So this is like a lung, upper lobe, left lung that we had received, and so I'll show you here the resected specimen of upper lobe of left lung, capillary lesion with aspergilloma. So we can see the respiratory epithelium. This so pus has made a sort of formation that there is this. And we can see granulomas, okay, and this is spongiotic dermatitis with dermatophytosis. So Gropots, methanomin silver, and more. So I'll now show you the slides of the case. So this is like a lung, upper lobe, left lung that we had received, and so I'll show you here the resected specimen of upper lobe. These are the granulomas, capillary lesion with aspergilloma. So we can see the respiratory epithelium, this fungal ball sort of formation. This is HNE stain. We could see granulomas, and we could appreciate angioinvasion. But one can observe that there is fungal ball formation, and because of the slides of the granuloma formation and angioinvasion, this is not only colonization by aspergillus, but invasive aspergillus. So I'm not. So these are the granulomas. So this is aspergilloma with invasive aspergillosis with fungal granuloma formation.
The slides have
So this is a case of they were suspecting it to be a fungal ball formation in a young male, because of 21-22-year young male, and granuloma formation presented with frontal of ventilation, colonization by aspergillus. These are the squash smear preparations. We could see numerous giant cells, and as I mentioned in the previous fungal staining, that we can see negative shadows on GINSA. Then we should suspect that there can be fungus, and we got a pass stain done on the squash smear preparation itself. So this is aspergilloma with invasive aspergillus. It was granuloma formation. Given a diagnosis of fungal case of they were suspecting it to be a tumor in a young male, 21-22-year young male, and later on clinically diagnosed as aspergillus encephalitis and combined clinical pathological and microbiological. So these are the squash smear preparations. We could see numerous giant cells. And as I mentioned, now we come to the next case. I had shown you two aspergillus case, one lung aspergillosis and one shadows on GINSA. And then next case suspect that there can be fungus, and this patient was a renal transplant on the squash smear preparation, and his foot was showing this type of lesion. On incisional biopsy was sent to us, given a diagnosis of fungal granulomas, and there was then we received nothing viable out there. The skin had completely necrosed, and there were these fungal granulomatous areas of fat. Later on clinically diagnosed as aspergillus encephalitis and combined clinical pathological and microprocessing issues. And when we went closer to the, now we come to the next case. I had shown you two aspergillus case, one lung aspergillus appearance, and there was some lighter small, and then next case is this surrounded by this patient was a renal transplant recipient, requested for special showing this type of lesion, like pass with incisional biopsy was sent to us. Alcian blue stains the capsule, and nothing viable out there. The skin had completely necrosed. So and there was this, and then these are necrosis, infarction, GMS stains for the patient. There are some processing issues, and the same patient then developed closer to the symptoms of meningism on a higher power. We could see the soap bubbly preparations showing the similar structures, small ease which were surrounded by halo. I'll show you the slides of the case. Requested for special stains like pass with Alcian blue. The Alcian blue stains the capsule, and the yeast itself is stained by pass stain. So this is, and then these are the GMS stains for the patient. So the same patient then developed typical soap bubble appearance of very nicely seen. These yeast are slightly varying in size, and some of them are showing similar structures, crescentic shape also, and the capsular thickness also varies. I'll show you and the capsule has some reflection of the virulence that also I had heard in Dr. Khurana say in one of the talks. And now I'll show you the special stain of the patient. So typical soap bubble appearance, very nicely seen. We can see the yeast are pink color and capsule is, some of them are slightly crescentic shape also, modification, and the capsular thickness also varies. And the capsule has some reflection of the cryptococcal cellulitis also. I had heard Dr. Khurana say meningitis for this case. And now I'll show you the special stain of the patient. So deep fungal infection, this is the cryptococci can have gelatinous inflammation or that is no inflammation, and because of the immunocompromised nature of the patients, or can have a granulomatous response. In this patient, we had this gelatinous cryptococcal cellitis.
We can see the E-sub pink color and the capsule is
cryptococcal
blue color
meningitis
because of the ashy blue.
So skin is a mirror of systemic
cryptococcal.
One must remember this.
I
have so needless to say, this is cryptococcal cellulitis. To the next case, cryptococcal meningitis in this for this case. So India Inc. And cryptococcal antigen was also faced. Now we come to the next. So deep fungal infection. 55-year female with large plaques on the back. Cryptococcal can have gelatinous inflammation or that is no inflammation, and because of the immunocompromised nature of the patients, or can have a granulomatous response. In this patient, large chunk of gelatinous cryptococcal cellulitis, and cryptococcal meningitis. In the subcutaneous, there is some inflammation. Cryptococcosis, one must remember this. There are some. I have weakly hematoxophilic. Now we'll move to the next case, and ribbon-like hyphal structures. So India Inc. And cryptococcal antigen was also faced. Now we come to the next. Some of them had bulbous ends. 55-year female with large plaques on the back, and it can be cutaneous mucorales, and discussed that they may be woody heart. So they may be woody heart mycosis also. Patients. So now I'll show you this is the skin biopsy of the patient. A large chunk of skin biopsy they have given us, and we could see that there is in the subcutaneous there is some inflammation, and there are some skin weakly hematoxophilic paucisaptate and ribbon-like hyphal structures. There are these areas of suppurative inflammation. They are and some of them had bulbous ends. So from the yesterday's talk, I felt it can be cutaneous mucorales and discussed with not much we are able to make, but there is an occasional hyphal structure sitting out here. Now I'll show you. But when we go to some other areas, we can find these giant cells. These bulky giant cells are sitting there, and there is some granulomatous response. And there are these large areas of infarction, as in the whole of the subcutaneous has infarcted. The epidermis, the dermis is not much affected, but when we go to here, we can see this ribbon-like paucisaptate hematoxophilic inflammation, fungal organisms, so there are these areas of suppurative inflammation. Not much we are able to make, but there is an occasional hyphal structure sitting out here. But when we go to some other areas, we can find GMS giant, wonderfully bulky giant highlighting there. And there is these are not just collagen; they have some internal nuclei of internal structures as the whole, highlighting that these are indeed fungal organisms. And here we can see this ribbon-like paucisaptate hematoxophilic fungal organisms. So next, I go to the next case. This is a 51-year female with headache, pain, swelling over right side of face, and we had a very important history that this patient was a post-COVID patient. So we could see that there are these GMS has worked wonderfully with fungals to highlight fungal colony formation. These are not just collagen; they have some internal new fungal organisms, structures to it. So highlighting that these are indeed fungal organisms. This photograph is showing you the nearby respiratory epithelial line mucosa, which is quite edematous, and there is a subjacent bone. And we could see that these fungal organisms are quite juxtaposed. The next case, the 51-year female with headache, pain, swelling, and right side of organisms were also very important nearby to the nerves, highlighting the perineural invasion. So, and we could see that there are inside the blood vessels also. There were lot of fungal. This was large fungal colony formation with presence of these broad paucisaptate fungal organisms. And
Madam, we need to wrap up.
Is showing last case. This is last mucosa, which is quite edematous, and there is a subjacent bone. And we could see that these fungal organisms are quite juxtaposed to the dead bone, highlighting the fungal osteomyelitis. And these fungal organisms were also seen nearby to the nerves, highlighting the perineural invasion. And so these sporangia, as Dr. Arti had also highlighted, that they can, these sporangiophores, they can become pigmented in mucorales, and there is this formation of a columella, and they are pigmented sporangia. Although mucor itself is not pigmented, but the sporangia formation is pigmented. So these are, and they are much larger. They are like 90 microns, and aspers would be very smaller. So. So complete necrosis. So these sporangia, as Dr. Arti had also highlighted, that they can these sporangiophores, they can become pigmented and destroyed everything, and there is this formation of the columella, and they are pigmented sporangia. Although mucor itself is not pigmented, but the sporangia formation is pigmented in mucor. So these are, and they are much larger. They are like 90 microns, and aspers would be very smaller. So. So complete necrosis of the tissue, and whatever is remaining is these fungal elements. And what we say is that it has destroyed everything else except for that it is fungal elements. They are feeding everything. This is fungal osteomyelitis. So mucor is quite destructive. So likewise, and these patients, they have lost eye angioinvasion and sinusal invasion. I had shown you in the photographs. The disease. So I think that is. So fruiting bodies of mucor and asper, sporangia are quite larger in them. They will not have any phylades. We are not seeing any phylades over here, and there will be 5 to 6 layers of sporangiospores. So this is the bone, and there is from my juxtaposition of these fungal elements. This is the fruiting body of asper. It is quite small. It is like 25 microns. So mucor can be due to all this, and mucorales and zygomyces. These terms should be now abolished. That is what I learned from taxonomy Lecture-5. That is. So I'd like to say some of the immunodeficiency diseases highlight some fungal infections. So fruiting bodies of mucor and asper, that if there is sporangia are quite larger in them, they will not have any phylades. We are not seeing any. So key points to remember: think fungus, 5 to 6 layers of compromised. Think fungus. Sample should also reach the microbiology department. And not from my own publication. Negative staining on the fruiting body of aspergillus is quite small. It is like 25 microns. I'd like to acknowledge patients, clinicians can be due to all this, and mucorales and zygomyces. These terms should be now abolished. That is what I learned from taxonomy. Thank you for this. And I'd like to say some of the immunodeficiency diseases. Thank you, slide, and we are thankful to God that so one has to remember that if there is any infections in a child, please think about PIDs also. So key points to remember: think fungus, patients with compromised think fungus. Sample should also reach the microbiology department, and not all granulomas are tubercular, and negative staining on routine stains, applied pass and
Thank you so much, Dr. Ujjawal and Dr. Tanya, for this
I'd like to
talk.
acknowledge patients.
Microscopic sessions are never so easy, but both of you nailed it, and I think even the non-pathologist sitting in this session would have understood the morphology of fungus. Thank you so much.
Thank you, Lord, for this angioinvasion by your slide. And thank you, slide, and we are thankful to God that we have been saved in at least till now.
Good evening, everybody. So it is indeed a pleasure to be with all the learned audience.
Thank you so much, Dr.
Now
Ujjawal and
moving
Dr.
from
Tanya.